diagnosis.
It has almost 75% mortality without liver transplant.
Yes, that's very important. So B virus, even though if the patient is going to land up with ALF, the chances of progression for mortality will be the higher side. And apart from the reversible causes will be HIV as well, HIV and all those things. Apart from, you should not forget these basic pointers like your Wilson's, autoimmune hepatitis if you're going to consider patient on steroids, as well as drug induced if you're going to manage promptly, you need to consider that. And this is what, and very importantly, see, if a patient comes to our OP with jaundice in the background of NCAF-like presentation, will you jump to the conclusion this is mainly because of ALF? No. So what are the various mimics you need to consider? What are the various mimics? All jaundice, does it mean you want to consider liver pathology or you want to look for some of the mimics which is progressing to that?
So we can also take into consideration other infective pathologies like leptospirosis, scrub typhus, malaria, dengue. All these are very common in our nation.
So non-hepatotrophic viruses, how many percentage will be more common to land with evidence of liver failure? Or 40 to 50% of the population non-A, non-E. Okay. Apart from that, other etiological things like what are the other mimics? Your pancreatitis, for example, the patient may have this kind of presentation. Your cholangitis may have this kind of presentation. So what are the things? Your meningitis focus may have this kind of presentation. Severe septicemia. Among the infection, in Indian scenario, as per your latest position statement in as what I mentioned, in Indian scenario, which infection among non-hepatotrophic will be predisposing to this ALF?
Malaria, sir.
Yeah, malaria approximately around 50% of the population may land up with evidence of malaria. So what's the treatment of choice you're going to choose once you're going to decide with malaria at the background of ALF?
Artesunate, sir.
Artesunate. So dose, you need to mention the dose 2.4 milligrams per kg and need to maintain for a duration along with doxycycline you need to consider if you want to tackle with malaria and other things. So look for the predominant etiology, assess the patient as a whole. That's very important to look into this mimic. So always you should assess mimic. Any simple pointers to remember. If in case if you are going to land up with evidence of three major indicators, do you have any indicator of derailment? Normal or only mildly prolonged. So which means the possibility for hepatotrophic virus to progress to ALF will be the lowest side. That's we should not forget. And etiological workup, very simple, all the basic virology screening, HSV, CMV, all those things based upon theoretical markers. But toxicology screen you need to do most of the time when you are going to suspect. But how far we are going to establish in India also the paracetamol dose, the paracetamol acetaminophen dose, toxicology screening and Wilson screening, all these things in etiological workup, huge battery of workup is there, but clinical assessment of the patient as a whole is very important. We cannot put the patient for all line of investigation, which is very, very difficult to establish in Indian scenario. So which will be the best thing? We need to focus, we need to assess the proper history and then we need to do a proper etiological workup. Prognostication is very important based upon that. So once the patient is going to have a liver transplant within 1 year, almost around 80% of the patient will be having a good survival rate. That's very important, and you need to be in state of heart centers. That's very, very important rather than going up. So when you're going to shift, what is the criteria for severe acute liver injury? Is there any criteria for that? So to shift the patient from your OP basis to the patient in the tertiary care center, is there any acute liver injury? Is there any criteria to look into that? Severe acute liver injury. Do you have any definition for that? There is against protocol being there for that. Do you have any guidance? Any one of the postgraduates?
If there is coagulopathy which is not improving, sir, plus there is encephalopathy which is increasing, the rates of encephalopathy is deteriorating, sir, plus if there is heart rate, the patient is in tachycardia, sir.
Leukocytosis, fever, leukocytosis along with NCAF and INR and bilirubin changes. These are the parameters. Why means all the patient will not land up with evidence of NCAF. This changes itself we need to pick up early to determine this patient to be transferred to a higher center. That's the definition for severe acute liver injury. We mentioned most of the guidance. So you need to see that. And King's, what is the role of King's? Various criteria are there to assess the patient prognostication as well as transplant guideline. Your Clichy criteria, King's, your so many models are there. So first thing is, what is the beneficial role of your King's criteria? Why King's criteria is more beneficial and not beneficial? If you want to look into can you able to point out what is the disadvantage of this King's criteria?
One thing is, it doesn't take the dynamic parameters, sir. And it has the low negative predictive values, sir. Also,
So yeah, fine. Tell me. The main thing is the low negative predictive value. There will be high specificity, but the sensitivity for your Kings will be low. Why means the Kings initially been coined within a duration of almost around 14 years of preparation for almost around 500 to 600 patients they have been survived, and then they have been looking into two major parameters. parameters. One is your clinical parameters and one is your etiological parameters. But they couldn't be able to establish a proper survival guideline. That's very, very important, because even if 3 or more parameters, if it tends to be positive, 80% of the patient is going to die because of this acute liver failure. And if 3 or more parameters, even though if this tends to be negative, still 30% is going to die because of this acute liver failure. That is why KCC you cannot take into account for most of the patient when you are going to judge whether the patient deserves treatment or not. So to change that, is there any other scoring system in your routine practice you can consider that? It is a prospective study.
Alpha scoring system.
What is it, Alfred?
It is actually having 5 parameters taking into consideration. The
No,
patient's-
ideally it is 4 parameters. 4 parameters.
The bilirubin being more than 15, serum ammonia being more than 123.
For hypertension, we reported for few patients, but even though we are not looking into much of scenarios, since most of the patients in critical care we are looking into, but even then, flushing, hypertension, still more patients are being there to report. But fortunately, we are having only one molecule to consider, so we need to start the patient. Oral means the dosage you start with, what is the dose we are considering for oral?
140 mg per kg, followed the start dose, followed by 70 mg per kg
For 70
for 17 doses.
So once you are going to initiate patients, so our target, we need to use your various procrastination scoring system and for modern things and all those things, and look for condition for liver regeneration and look for optimization for transplant. And in intensive care, the intensive score is coming to the so we need to target our central nervous system. It's very important. Your respiratory, your hematological parameters, and your infective parameters, metabolic parameters, nutrition factors, all these basic things we should not forget when you're going to tackle a patient in intensive care. First thing is very important to address your cerebral perfusion. So what are you going to do? How are you going to recognize ICD? What are the various methodologies to recognize ICD?
There are non-invasive methods to measure and invasive methods. And non-invasive methods, we can measure optic dosing diameter.
So what is an optic diameter? What is you are going to use a linear probe? Okay, with that, what is the cutoff you are going to take in the probe?
Sir,
It
it
is going
is
to be
more than 4.5 to 5.5 ml.
Okay.
When it below the retina,
when it is how many millimeters below the retina level? 3 millimeters. So 40% of the population will be very difficult for you to diagnose. So in that kind of pattern, you are going to progress. And so first we need to identify the etiological triggers based upon your paracetamol, Wilson, Amanita, so many other etiological causes. So identify the cause, treat the patient, very important. If the drug is used, affirm the drug, stop the drug. And apart from that, ectrophic virus B and other things, you can easily, you can start the patient antiviral support and all these things. And atonement and bad is very important. You should not consider. Always you should consider when you are going to tackle, because
Support IPS it's fast. IPS with the loading dose of 150 mg per kg body weight with for 1 hour, 450 mg per kg body weight for next 4 hours, 400 mg per kg body weight for next 16 hours.
so totally you need to target around 300 milligrams per kg over a duration of 28 hours. That is the target. So is there any adverse event for NSS in any facial flushing, hypertension, whether you are coming across any adverse event when you are going to use a NAC? How far? Worsening of symptoms within 2 days with hemodynamic instability in the background of recent history of travel. All these things, what would be the most likely etiology you would like to think? What is the most likely cause? What's the presentation?
Sir, I would like to think viral etiologies first.
Okay.
As there is a history of travel and the patient is a
Okay. So since the patient had history of travel, okay. Apart from that, what are the etiological events? Since the patient had jaundice, in this history, what are the etiological events you can think in terms of?
Sir, other it could be some drug induced or because she has taken over the counter medications for a period of while.
Okay. Could it be because of acute liver failure, or you are just simply tackling a scenario of acute hepatitis? What do you think about that? Aditya.
Since in the case study, patient has there is icterus and also there is causiness.
Question the patient's nationality, acute viral hepatitis remains still the most common cause, being hepatitis A and hepatitis C. Since in our nation we are using lots of herbal medications, and since India is also the hub of tuberculosis, drug-induced liver injury (ATT) being the first possibility, followed
But
by
ATT, the patient has not taken any history, but based upon this
Can
picture,
we take
it
his
might
case?
be because of complementary CAM and other things, along with hepatitis picture and over-the-counter medications like acetaminophen because of history of trauma. And in the childbearing age, even though it's not signifying history, we need to look for features of. So basically, when you want to look into the diagnosis there, what is the basic definition for acute liver failure? In Indian scenario, multiple papers, more than 50 definitions are there for acute liver failure based upon your INASL. First, we need to look into Indian National Society guidelines, what they are saying, what is the time duration. So what do you mean by acute liver failure? What is the time duration they have been looking into that? Anyone?
acute liver failure defined.
Farhan, you can come.
It is defined as
So as per INASL, you need to stick on to the guidelines. As per INASL statement, what is the definition they will be looking into that?
it is defined as acute liver injury presenting as encephalopathy with coagulopathy, jaundice within a period of 4 weeks.
In the background of a normal labor.
No.
So you need to consider in the duration of 4 weeks, because most of the guidelines they will be sticking on the for example 8 weeks, 12 weeks and all those things. For example, Trey et al. They have been mentioning the guidelines for 8 weeks, and Overgrade is mentioning guidelines up to 12 weeks. ASCD coming with the guidelines almost up to 26 weeks of duration. And our INASL, why? What is the reason? Can anyone be able to point it out? What is the reason we are sticking into 4 weeks? Any of the postgraduates? So almost.
Here, the most common etiology is viral hepatitis, and
No, not only based upon the etiology, and in our Indian scenario, around 80 to 90% of the population will be lining up with this kind of, in earlier presentation will be. So that's why we need to look, most of the acute liver failure worsening events will happen within first 4 weeks. So the crucial time we need to take into account, rather than thinking for more than 8 weeks of duration in our Indian scenario. That's why our INASL goes with guidelines of 8 weeks, even though most of the most of the other societies not sticking on to that. Okay? And based upon that, how are you going to classify? You can be able to guess it out. How are you going to classify that?
Liver failures are classified into hyperacute, acute, and subacute. So hyperacute means time to jaundice will be less.
What is the necessity for us to classify this? Is there any role? So what's the role?
Yes, sir. Because hyperacute and acute liver failure will have higher prognosis, deterioration rate, but it will have incidence of severe edema, sir. But it will recover by itself also, sir. Acute liver failure will progress slowly, but it has higher mortality rate.
So